Have the difficult task of nothing to disclose, and the even more difficult task to talk about liquid embolics without talking actually about liquid embolics. So I try to talk about how to select the patient for the procedure from a clinical perspective, and also about the selection of the agent. And well, the easy thing is liquid embolics are used everywhere, actually. You know, you see them everywhere for everything, every time. So it's a great thing. But obviously, that was the easy way out. Clinically, we have to decide, do we look for endovascular or for percutaneous procedure? Because liquid embolics can be used for both. We have many indications. One of the things I do most is AVMs and pseudoaneurysms, but it can also be used in erectile dysfunction. GI bleeding is something I really don't like, but there's a lot of literature out there, varicoceles, pelvic congestion syndrome, portal vein embolization, and so on. So there are really many indications for using liquid embolics in clinical practice. But there's a critical part is to find the ideal patient. So let's see. We have a lot of different embolics here, which is fibrovene, which is more or less a sclerosant, not really a liquid embolic, but we saw some like squid. We very often need lapiodol to get our liquid embolic, like histoacryl, so MBCA running, or to visualize our liquid embolic. Also alcohol. So ethanol is a nice liquid embolic. You see, we have a broad range of products clinically available and even more awaiting to appear on a market. And we also have coils, plugs, and particles. And to be honest, at least in my practice, many of the procedures are a combination of coils, plugs, and liquids. So the choice of embolic is really a competitive decision. Regarding patient selection, and that's really the crucial point because we need information about the patient to select the best embolic. Well, when does it happen in the IR workflow? And from my perspective, it happens in 2 points. First, when you see the imaging and decide, wow, how to get there best and how to occlude the vessel. And the other thing is during the physical and the medical history, because there is a lot of information that is needed to choose at least between embolic, ethanol, or sclerosant, and even between embolics, it may make a difference. So that are the questions during advanced plans and planning that I ask myself. What am I aiming to achieve? Do I have the expertise, particularly between liquid versus mechanic embolic? It's in the end, it's a question of training. Sometimes it's also the question, do I need assistance from a colleague? Maybe if I have to flush the catheters very rapidly and so on. And in the end, am I equipped to manage complications? Because complications with liquids are definitely different from complications with coils or plugs. So I need to be prepared. And anyway, I need informed patient decision. So it's just a selection of factors actually that affect my decision. First, I ask, what type of procedure do I do? Do I do a VM or a AVM? Makes a difference for me if I go for glue or if I go for a sclerosant. I'm sure we will hear more about it. Accessibility, how close can I get to the nidus? If I really make it into the nidus, I can nicely go, for example, with Onyx, but if I can't reach the nidus and if I have to fill the last centimeter, including the nidus, I definitely would go for histoacryl. So that's part of the decision process. Again, it's more or less related to the deepness of embolization and the intended effect. You know, if I want to do a PVA, I'm really happy if I get inflammation. And NBCA, so histoacryl, is best in this way. It's much better than using any other embolic for portal vein embolization. Coagulation state might be a question, as well as comorbidities. And I will show you a case later where this is decisive. Structures at risk, target lesion localizations, and know is it superficial or deep. With superficial, lesions, I wouldn't go with something that causes inflammation, like histocryl, because that's really painful for the patient and can even cause skin laceration. I've seen this before, so I wouldn't do this. Required speed of embolization, what's the coagulation state like, and obviously the local expertise. If you're in a center that does a lot of liquid embolizations, you feel more confident when you're in compared to a center that uses mostly mechanical products. Well, let's go through some examples. This is a patient with a huge, or actually multiple, huge hemangiomas and symptomatic. So while reviewing the history of the patient, I came over this X-ray image and was wondering, well, what's going on there with the lung structure? And only when I asked the patient about the history, and it wasn't documented in our hospital's records, I learned that this patient had a problem with the lungs. You very often see this in the area where I live. So that's not a patient to go with bleomycin. Definitely not a way. Although bleomycin is pretty potent for this type of hemangiomas, but not in this particular patient. A different example, that's a patient having a huge spleen due to a hematological disorder, but the patient also suffered from portal hypertension, underwent a TIPS procedure before, which was quite successful, but still that's something to consider. And I just chose this case to illustrate and highlight how important it is to really see the patient. You need to undress the patient to know what's going on. You need to know about the abdominal collateration, ascites, edema, and so on. Even if it has been treated by a TIPS, you need to know if it's efficient or not. So really undress the patient, see what's going on. Another thing is you need to talk to the patient. Otherwise, you wouldn't learn in the cheapest way how the patient feels, what his mental capability is like. It's particularly true for portal hypertension patients. You can also do easy number connection tests, for example. That's a 30-second thing to do. Well, maybe 2 minutes, but it's definitely not longer. And finally, it's not only the physical exam, but also looking for lab values like indicators of cytolysis and so on. In this particular patient, you see hypersplenism, but not due to portal hypertension, but due to a hematological disorder. So we not only have to look for the platelet count, but for other indications of his or her problems too. Well, that's not so important. The key point is really look at the patient, talk to the patient, and look up the history, including the lab values and older imaging. So in this particular occasion, we went for an embolization with glue. You see already the arterial catheter. You see the post-embolization results. Looks a little bit huge, but it's not as big as it looks here on the coronal view. And this patient really became normal with thrombocytes within days. So very effective thing. Another thing to look is what's the access route will be like in this type with an endoleak. And the endoleak can nicely be seen, but here is no easy arterial way to get there because both iliacs were crossed by the stents, so it wasn't easy to get there. And the percutaneous route would be the obvious choice in this particular patient. Here you see the needle in place directly behind the prosthesis. Imaging, we are in a lucky situation to have access to a hybrid CT angio unit, so that makes it much easier to control. And we nicely see that our embolic agent reaches the lumbar arteries in a way that we want to have it. And the last case, typical portal hypertension case, and you saw before what to do if you have a portal hypertension patient. You see the huge spleen here, and it looks completely different from the spleen in our hematological patient, although they suffer the same problem. You see the TIPS, but after TIPS, you still see the esophageal varices, and here it's crucial to embolize. And in such a patient, we usually don't go for a glue alone, but we combine a mechanic obstruction, in this case a plug, with glue to make sure that the glue stays in this way just to slow down, and using the glue to make sure that it's really properly occluded. So in the end, my summary is look touch, talk to the patient, think about what you're doing. That are all the steps happening before you put the patient on the table. Thanks for your attention.